Bonjour à toutes, bonjour à tous.
Hello, everyone.
La table ronde
So this round table, yes, indeed. Well, the previous round table was talking about the proximity. So right now we will be talking about the opposite thing, the distance, the remote possibilities, meaning the healthcare jobs that will be remote. And this is also, well, we will also be talking about the care, medical care or paramedical care that will be remote for the patients. So this care, remote care, is not something that is very new. This is a reality that is part of our ecosystem of healthcare right now, and patients are using it more and more right now. In 2023, 4% of all the consulting for the general practitioners were teleconsultations, and this is 70% more than the year before. And the health professionals are also appreciating it a lot because they believe that the teleconsultations allow them to much better tackle the issues related to the health of the clients. And also medtech, startup, Adequity, and many others are investing massively, and also the public sector as well, are massively investing in the world sector of telemedicine, and we believe that the growth will be for the upcoming years up to $300,000 million. So we basically are talking about very, very important and big figures. But not everything is very positive in here. 1 doctor out of 4 is very reluctant to this idea of the teleconsultations, and 1 out of 5 of these teleconsultations is not respecting the protocol. And we also look at the patients, and we see that most of them are not really living in the medical desert, but are urban dwellers. So what to think about this remote jobs, up to where, to which extent? So this is the question that we have here, and this is the question that our debate will be tackling. And for this, I have 4 very interesting people who will be here with me with very different points of views, and I will be basically introducing them very briefly. So we have, first of all, Isabelle ADENOT, who is the president of the French Agency for Digital Health. We have Kalle, who is the deputy CEO at CRY at Sweden.
Which the audience may know in France as Levy, one of the European leaders in digital first care. Ali, cofondateur de SquareMind, une startup franco-américaine.
Ali, who is the co-founder of SquareMind, which is a startup French and American who is working in dermatology, and this is quite an innovative brand as well. And finally, we have Alain, who is the professor of medical studies from the French Society of Radiology and Medical Imaging. So for this very beginning of our debate, I would like to give you the floor, Isabelle, for the first question. Do you think that all of these remote jobs, or at least a part of them, will be unavoidably increasing in the future? Or, if I formulate it differently, what will be the needs that these remote jobs will be covering and satisfying? All right. Thank you. Well, as it has been said this morning many times, the digital things are already very much in resonance and echoing throughout our epoch. And it's actually very obvious because we can see many people who have their smartphones, and I have it as well. So it actually means that our way of communicating and living changes a lot. And of course, at the level of healthcare, things are changing just as much. So I will not really use the word unavoidable that someone has used before, because for me, unavoidable is, oh my, I wasn't able to avoid this disaster or something like that. So it's basically this negative connotation that is kind of associated to it. But I believe that in telemedicine, we see that the physical interaction is basically the guarantee of the quality, and the trust is possible only when we have the direct relationship. But this is partially wrong. So I think that unavoidable, this is the term that kind of would relate to this negative side. I would say that this is a cool thing, because I think that the digital is basically a leverage for the innovation and for the improvement. So now, what will be the place of the remote job with respect to the physical jobs? Well, for me, the patient and the professional, whoever is this patient, they will be basically fixing their limits themselves, but these limits will not be fixed. These limits will be evolving in time, and of course it will be changing throughout the time, and it will be changing either collectively or individually, because each and every one of us at a certain point wants to use something remote, and at another point just wants to do things differently. So I believe that all of this balance will be changing all the time, and whenever we will have a crisis, well, we hope we won't have any sanitary or health-related crisis, then we will have changes in all of this. Or if there will be, let's say, a leakage of data, it will go elsewhere, it will go in the opposite direction, I think. So now, is there an appropriation of remote jobs? Yes, of course, this is obvious. The technologies are more and more operational, and what I can see here are two things that are very important for me. And this is, first of all, the internet bandwidth that is increasing, that allows us to transfer big files, and I'm thinking here about the surgery, remote surgery, because this is not just teleconsultations that we're talking about, but we also have some other jobs that are possible here. So the bandwidth is the first factor, and the second factor is the generative artificial intelligence that will help us in using the digital things. So we have the captors right now that can be implanted or not everywhere. We are talking about the smartphone, but we also have the smart cities, we also have the smart men and everything. So the captors are everywhere. So this is like the difficulty of the access to the healthcare is also an important issue. We can see it, and we can see that from one point it means that there is no health practitioner, but from the other hand, we can see that for some people it can be difficult to come somewhere geographically. And I'm here talking about the age or the questions related to bad weather, etc., etc. And on the other hand, from the point of view of the patient, but also from the point of view of the professional, there is this willingness to have something hybrid, something that will be much more flexible. There was a patient who said it this morning during one of the round tables that they want to have additional flexibility. So personally, I'm convinced that we will be having more and more jobs that will be possible to do remotely, but the limits of all of this will depend on ones and the others, on all the stakeholders, whoever wants to do what and whoever is willing to accept what. So yeah, so now Kalle.
Everywhere in Europe, not only in France. What's fueling remote care? Why do healthcare professionals come to you?
Yeah.
And is it going to expand?
I think to follow on what my colleague said here, there are two things that makes remote care unavoidable in the future. One is to match where patients actually live and where the doctors are. Today in Europe, in all of the markets, we see a huge inequality, as you alluded to, that in the inner cities, where all of the doctors live, because they live where the population lives, you have good access to care in many cases, but if you live in a medical desert, if you live further away, or if you're old and you have a trouble transporting yourself to the physical unit, you have much worse access. We cannot accept that, and that means that we have to match supply and demand better. The only way to do that is via remote work from the doctors to where the patients sit. That's one of the reasons why this is unavoidable. The other reasons is financial. Today, we provide almost 99% of all of the healthcare in physical units that cost a lot. They have infrastructure, they have rents, they have machines, they have laboratories. But if you look at the data on what the patients actually do in these physical settings, you will see that about 60% of all of the visits do not use that infrastructure. They simply meet a doctor or another clinician. They sit across a table and talk to one another. We have to move that to a lower resource setting to free up space where it's most expensive, in the hospitals and in the clinics. And therefore, we also need to go towards remote working measures. To your question on for us, I mean, we have 4,000 clinicians working with us across Europe, in France, UK, Sweden, and Norway as of today. They come for many reasons, but one reason is that many of the doctors choosing to work with us, they say that they feel a moral obligation to be able to improve access in other parts of the country than where they live. That's one of the reasons why they want to be part of this. And then obviously the more personal reason around having flexibility in life, being able to do 1 day or 2 days from home. instead of having to travel to a unit. So I would say those are the two main reasons why doctors choose to work for us.
Thank you. Donc on comprend quand même de vous deux que...
So we basically understand from both of you that the remote care, this is something that is unavoidable, that this is something that will continuously develop. And right now I would like to do this small exercise, which is not very easy. Well, we are not really talking about the question that we are going toward the status quo. I believe that we will be going even further, but we will be doing a little bit of science fiction. So let's look at 10 years, 10 upcoming years. So in 10 years, what will be happening in terms of healthcare in dermatology, for example? Yes, of course, because you're working in there, and probably also for the rest. Well, yes, indeed, I can talk about dermatology because first of all, we can talk about the state of things, and it is quite clear today and quite worrying the situation that we have here on most of the French territory. We understand that and more territories are becoming the medical desert, and we have a lot of waiting time in order to have a consultation for the dermatologist, and sometimes it can go up to 12 months. So just for the appointment, and some will not accept new clients. So this is a big problem, and there is also a territorial problem because sometimes you have to travel some 100 kilometers in order to have the access to the practitioner. So we have this particular point, we have the geographical and temporary access, and unfortunately if you're waiting for 12 months and you have a very important urgent problem, this is really an issue. So what we're doing today, well, in teledermatology, this is also a remote job, I would say, but this is not very operative today because we don't really have tools that allow us to be much more performant here, because it's not really with a smartphone that you will be able to really well supervise a patient remotely for dermatology. So we are talking about the future here. We haven't really developed things right now. We are talking about some dozens of years, I would say, but we can imagine that probably a patient will be able to have an appointment with a doctor and then either to go to a center, prevention center that is quite close, or to have a different like healthcare center or whatever, where they will be probably scanned, like digitalized in a couple of minutes, and we will be generating this very high fidelity image of the skin situation of this particular patient, and the data will be quite exhaustive for all of the body, and this will be probably the definition of the standardized approach to the imaging. But I don't really know whether this will be an exhaustive answer that we can provide. But this will be something that will allow us to fight against this medical desert situation that we have right now, because we can still imagine that we will have the dermatologists that won't be present all over the French territory. But that's what we can imagine in terms of the technology, I would say. Yes. So, well, as you imagine it, so I'm going there and I'm being scanned, and I am comparable to a mass of data of some other patients somewhere else in the world. So I imagine that this will be artificial intelligence that will be basically doing the diagnosis for me, detecting possible issues and diseases. So the dermatologist's role here, where will this be situated? Because like in 10 years, we will be just like in the movies, coming into some sort of a cabin and being scanned, and well, what will happen to the practitioners? Well, they will be here, they will be helped by the artificial intelligence, but their expertise is very much needed. But then the continuity of the care is basically the main issue. So either the practitioner will not see any problems, or they will find a problem, and then there will be an issue of this territorial access. So probably they will have to send the patient to do the scan again somewhere where there's to a closer place for the patient or whatever. But I think that the physical presence will still remain. The physical care will still remain, but remote part will be very important.
In many countries, some probably more advanced than France in remote care. 10 years from now, what's the major changes in the patient management?
I think that what needs to happen, and you're right, in some countries in Europe that has come a little bit further, I think that we have to stop talking about digital care and physical care. There is no such thing. There will be no patient 10 years from now that has either physical or digital care. Remember that the majority of the patients that we treat today, or we don't actually treat them for their disease. They will die with their disease. We are managing it. and they will have a number of interaction over the years. When the physical unit or the infrastructure around that is needed, that's where they should be. But when it's not, we shouldn't use that resource for these patients. So I think what you can do as a country is, of course, equalize them, make sure that digital and physical are not two separate things. I think also that the trend is going towards capitated measures of handling patients in the Nordic countries. That basically means that you get a certain reimbursement, you take care of all of the patient needs, and if you do that effectively as a care provider, you're good. If you don't, you have a problem. And that is probably where other countries will be moving as well, I think.
Thank you.
We have also touched upon a very interesting point that I believe is very interesting for many people, and this is like physical and digital and this opposition or interconnection. So how can we interconnect both of them? So I believe that probably in the shorter term, the growing part of the remote that is coming, will it change completely the patient's journey? How can we coordinate the physical and the digital tomorrow? Alain? Well, thank you, Nicolas. I believe that this is a little bit more complicated because within 3 years we will be able to double-check what we are talking about today. And I think that there is a very important point that you have mentioned at the very beginning. So who we are addressing today? So are these the patients that are like really here, or the medical experts or paramedical experts? So who we are addressing here? So first of all, we are addressing people who have some problems with proximity. So these are probably people who will be young, who will be very good with digital technologies and so on. And we also understand that all of these tools, remote tools, are complementary tools to the doctors who already have a lot of information. So basically, it goes back to this question whether it does provide something in addition to all these issues that we have today. But I think that we haven't asked this question yet, but this is coming for the moments where it will be absolutely needed for us to have something remote, but also the moments where it will be absolutely needed for us to have a physical presence. So if we look at different domains, let's say a little bit more than radiology or imaging, if we have to contact the patient and also this trust that has been established, this is something that will be here. But for the interventional imaging, we will continue doing all these live procedures. Nonetheless, we also have some areas where, let's say, a patient will be coming at very late hours and they will need some expertise. So we already see the place of these remote tools, and they're already here. This is perfectly here and perfectly adapted. I think that these moments are not yet very well defined and not very well articulated, but that's very important. And the third thing is that we didn't really do all the technological revolution that goes with it, because we actually took the tools and we said that we will be using these tools for the remote as well, but we haven't transformed the thing. So when we're doing a teleconsultation for the radiology, let's say, for the imaging, so we have the screen, the computer, and we're reading these images, but can we ask for the patient to come and see us directly? Do we have all the necessary tools for that? Can we share the synthesis with the patient through the digital tools and so on? Well, this is not something that we have completely done right now. And this is also an important stop or block, especially like for the imaging, I would say, and radiology. And this is also something that questions the place of all the digital tools. And I agree that talking about the proximity, right after having talked about the proximity, talking about the remote jobs, we would think that this is opposed, but we would also think that it will probably create some competition between the two. But I believe that this is not the case at all, and we have to find the right place for all of them. And the British Core Association has basically done this study in 2022, and they have been talking about the strategy of follow-up of the patients with the heart after the heart stroke. So we see that we have alerts, we have the home interventions, we have the remote things, we have someone who will be detecting and identifying the alerts that will be the best operator of this coordinated patient's journey. And I believe that we have to work on that. Right after the ethical questions, we have to understand whether we have to be monitored, all of us, whether this will be health at any cost, whether we have to have all these captors, all the sensors everywhere. But I believe that here we have to go back to the very first debate that we have had in the first roundtable this morning. Ali, we're talking about this fusioning of different technologies, of the sensors everywhere, the connected world, and things like that. So today, what is your feeling, because you are working with medical technology? So do you feel that something is lacking somewhere? Well, a certain link between technologies, or do you think that all the tools are already ready for the remote work? I go back to what has been said by Isabelle, Kalle, and Alain. I believe that we are like the telemedicine is for tomorrow. So the imaging that we are talking about right now, tomorrow it will be a different thing. Just to give you different examples, I can see right now 3 types of technological innovation that will change the ways of practicing the teleconsultations today. But also going back to your first question, the journey of the patient in general. So just to give you an example of the teleconsultation today, just to simplify, this will be a video exchange between the doctor and the patient, and this will be done by a video conference. Now, when we have some sensors, we have very few information right now. We have some companies here in France, but also in the United States. In the United States, we have Bina. They have developed the smartphone apps that will be coming to the market that will allow us to, let's say, take a smartphone and do the analysis through the face, do the analysis of all the heart frequency, the rate of hemoglobin, the level of stress, and vital components of a human being. And I believe that this will be enriching the teleconsultation as we know it today in a considerable way. So this is the first axis. The second technological axis is the connected world with the sensors, and I also see this third axis for the dermatology, teledermatology, and this is what I see for the disciplines. This will be like the breakthrough technologies that will completely break the status quo and completely change the patient's journey and will facilitate the telemedicine a lot. They will also change the nature of all the stakeholders that are implicated in here. So just to take the concrete example of the ophthalmologist, this is something that we already know, and the patient journey has transformed a lot. So if we look at the analysis of the eyesight of the patient and go into all the way to the definition of the optical correction, well, it has been transformed considerably by the invention of different machines. So now the doctor is basically managing everything from A to Z. So they capture the data, they analyze this data, the machines are doing this, and then the doctor can basically focus on the highest added value, which is the medical analysis, and the technical acts are basically delegated, and this is being measured by the machines. So what I would like to say here is that what we will see in the telemedicine, well, this will be the innovations, technological innovations, but also the delegation of competencies that will be coming with it, and this will need some collaborations between all the different functions, medical but also paramedical, under the supervision of the medical professionals, because they have this responsibility on them. Okay, now we would like to go to the next sequence here, because when we're talking to which extent, it means that there are some limitations here. So we probably should fix some limitations here. So the very first question probably for you, Isabelle. So what are the limits, the mandatory limits to the developing of this remote job? So what are these limits? Well, first of all, I was already smiling with this topic of the round table, to which extent, because most of my professional career and still today, I have been pushing these limits. And so the question for me is not to which degree or up to where, but how to really implement and how to do the surveillance of all the work that is done by all the collaborators of the agency and all the people who are working with the agency on the territory, because we are much more talking about the implementation. So to which extent? For me, this is a curious component here. So now, to go back to the question related to the limitations, talking about these limits, there are some stakeholders that are doing a lot of things. We have seen it and we have mentioned it, and what is happening here is absolutely huge. So I don't think that we totally and completely perceive what is coming. So when we're talking about the health authorities, this is huge. So the question here is, do we want to react at what is coming, or do we want to have a proactive approach and carry forward these transformations so that the healthcare system will basically integrate the digital as a lever for the improvement? So we are persuaded, we're sure that the digital will basically add something. So do we have to give carte blanche to everyone? No, we have to have a framework. So this is what I was telling to Guy. We have some norms, so we have some decrees and so on. And this is a little bit difficult, but it's still very interesting in terms of the telehealth to create a certain framework so that all the stakeholders will be able to evolve within this framework. It means that it will be quite broad, but we will still have some limits that must be here. So, for example, the framework that is admitted right now, because we have talked about this text that have been issued, and it is about the healthcare professionals. So the healthcare professional must respect their deontology, because we have already had some questions about this, and respect all these conventions that are pretty much assigned for each work, for each job and for each teleconsultation. So from the technical point of view, this framework, it will be the interoperability, the safety, because we cannot, these are non-negotiables, I will say, and also the ethics about the data usage. These are the red lines that must be here. So the health care authority is creating the documents about the place and the environment. Well, of course, we cannot create a teleconsultation, and do it, let's say, here in the middle of the room, in front of everyone. This will be absolutely impossible. Then we also have the questions related to the structure that will also require commitment from the healthcare professionals. And this is a true question. And what is also very important for the healthcare professionals, so right now we have all of this and it's already issued. So first of all, we have the certificate of the agency of the ANS. So this is for all the technical questions, and I'm really skipping the details here. And the ministry is basically giving the license to all of these companies. Well, right now we have 3 of them, and 3 of them are certified. So this certification is done every 2 years. So these are the things that, if you want, are fixed. Now, we also have some things that I believe are a little bit more vague that exist today within the framework, and probably it will be evolving in time in one sense or another, even though the intellectual concept is very interesting here. So first of all, the coordinated journey. Well, of course, this is something that must be created, but we have some people, 5 million people who don't have a general practitioner, assigned general practitioner. So the territoriality, yes, well, we agree, but the intellectual concept means that we can reorient or send to another place people because we know our environment. So this concept is very good and very interesting. Well, okay, if we don't have a practitioner, well, we don't have, because we have exceptions everywhere. We also have this question of the of a certain line here. So we also know that this is the line not to cross probably, but is it good, is it not very good? But we cannot really have a carte blanche to everyone. As Dominic was saying, just in terms of the digital, we have to frame some things, and they have been framed, so we don't have to reinvent what has been invented already at the European level and to create French something. We already have a European framework, so this is enough. And then I think that some things will probably adopt a little bit in the future. Alain, probably an additional question for you with respect to these limits. Well, these limits are potentially mandatory. This will be like the measurable goals for quality, or, well, around the healthcare professions. So we can think about what is this quality of the medical service, what is the client's satisfaction, the financial goal, and so on. So we have been talking about it for a long time right now. So I'd like to ask, do you see whether there are some quality indicators, specific quality indicators that would be specifically interesting, that should be probably stored in the future, so that to guarantee this quality for the remote medicine, for the telemedicine for everyone? I would say that this is complicated to define very clear indicators here. First of all, going to the population, looking at the population that has the access to telemedicine. This is like a complementary tool, and I think that the mapping, we will have it, and it will be much more detailed than what we have today. Now, going back to the reflection that we have had already for deploying the telemedicine, but this is a little bit like broader than that, to have some modules and to carry them by planes to some territories that are very remote, let's say Canada or something like that. But before deploying this plan, they had a mapping, geographical mapping, and they have explored the demographical criteria, but also the access and digital data as well, so that to understand like the places where I need to install all of this, I must have all the digital tools that will allow for it to work. Do we have this mapping? I don't really think so. Well, we have talked about this digital this morning, and I can just go back to the SFR group. This will be the challenge tomorrow for all the healthcare practitioners to age better. Do we have this mapping for all the population to understand where are the people who have some disabilities and so on, and disabilities also in terms of the access to technologies that we're manipulating every day. And second, we have this indicator that has been already expressed by the patients, the indicator of the patient satisfaction that is based on the trust, because we need to make sure that the offer will not be degraded, and all the charters that we're creating, the laws that we're creating are here so that to guarantee that telemedicine will grant the same quality as the physical presence medicine. And the third marker, I think, this is the technology, and you have already said it, this is the major issue, especially for the surgical robotics, but we understand that through the last meta-analysis, we can see that we still have some issues here, because even though we have some latency here, this latency is basically an obstacle for us, a hurdle for us to have the remote surgery. So can we go faster than the 5G, still remaining sustainable? That's the question, because we are in this environment and we have additional consumption that is generated by all of this, so we have to think about the sustainability. This is also a question at the level of the society, the question related to the future of our country as well as of the world. Yes, societal and this transition, and we haven't tackled one of the points which will be one of the major topics of these debates as well, and this one is basically like the main topic, I would say. This is the financement, the money, of course. So you, Ali, you are an interpreter, so you know France, but also you know some other systems, and specifically American systems. How do you see the financement of these technological innovations that are basically generated by all these teleconsultation jobs and remote jobs in France? Well, I think that this is basically a continuum that I see in two parts. There is this first part, which is basically the financement in terms of capital risk of all the innovation of technology. So it means that the technology has to be developed so that for it to come to the market. So this is the first part of the financement. And the second part, this will be the financement of the whoever is paying. So do we have a refund system that will be, well, possible here, so that to allow to have this telemedicine here, but also to have some estimations and to adopt it by the health, to make it adopted by healthcare professionals. So I'm not saying it for pleasure, but I'm convinced that this state has done a lot in this field so that to support these technological companies. But the problem that we have, the gap that we have, is the private financement, and I don't have a solution for that. But the private investment is not really here so that to try and finance this type of society. But if you don't have the private financement, you cannot have the access to the public financement. And just to tell you that you need many millions of euros so that to develop a revolutionary device that will be used in the future, well, you understand the situation, and this is the very first point. And the second point is for the payer, and I think that we still have a lot of initiatives that are very positive that have been adopted throughout this last few years. Well, we have the Article 101 that allows us to test the innovations beyond the common law, and we have had some refunds in telemedicine that we have that are absolutely real, that exist today. Of course it can be improved, and this is not the case everywhere, but it exists. And I also remember that Isabelle was referencing it, the cap of 20%, this bar of 20% was basically lifted for the teleconsultation, and this is something that will go in favor of all the expertise. Of course, I understand that we can go even farther here, especially for in terms of jobs, because we can look at the quality of the care that patients are receiving physically or remotely. So if we believe that there is an equivalent of the quality in healthcare, so why won't we install the equal refunds? And I'm thinking about the United States and the system that they have there. So to have this payments that will be done by the Social Security, that will be basically equal for the remote as well as for the physical presence, for the healthcare and physical presence. And I'm also thinking about the mental health patients, and right now it's actually very expensive, and in some 15 states in the United States it's already installed. And I also can see that the Medical Scientific Association in the United States, or scientists, are basically the drivers of all of these innovations and all of this progress that we have in remote healthcare. So that's how it works for the healthcare professionals.
As you said earlier, you started touching the point of capitation. In France, it's HCPs are paid on a more or less consultation fee per consultation basis. You are familiar with other models, especially capitation, in place in Sweden.
Yes.
Can you describe a little bit how it works in real life and pros and cons?
Sure. I think that both Sweden and all of the Nordic markets and the UK have moved to capitation to a large extent. The simplest reason for that is that it's impossible to budget for the nation if you have fee per action models. You're driving fee per action, especially if you start separating what you pay for a particular type of visit. It's a big mistake that was made in Sweden, that you had one fee for a digital consultation and another fee for a physical one, which obviously drove patients in different directions, not necessarily based on need or based on what was suitable. Capitation means, of course, that you get paid a sum for taking care of a patient's all primary care needs. And then whether you do a digital or a physical consultation doesn't matter, you get no extra. But obviously, if you are not effective, if you're not treating this patient well, you will have high costs. And that also creates an incentive for doing preventative work, to making sure that the patients that you care for are kept in good order and not more ill than they have to be. So I think that we are at a time where we still talk about having different quality regulations and different rules and so on for digital and physical care. That's a mistake. The Nordic countries did have that, have moved away from it. The standards are exactly the same for physical and digital care. Doesn't matter. This is the standards you need to uphold, and these are the expected results. And I think that France will also have to move in that direction. That is my personal view.
So we are coming at the end of our debate, and probably to conclude, understand that we have many representatives of the pharmaceutical industry, but also medical technologies, financiers from private sector and public sector as well, who are present in here. So probably one of you or all of you, you would like probably to give us a certain access for the further reflection on the development, harmonious development of the remote jobs. Well, integrate all the time the digital. Do not leave the digital aside. So these are all the reflections, and I'm actually very happy that the High Authority of Health in the very last document has integrated completely in all their recommendations the digital as well. I believe that everyone must integrate it. Yeah, we have to structure the journey, and we see that for the radiology and medical imaging, the digital part is also coming in. This is integrating the patient as well. So I think that this is something that we should be happy about. So we have to talk about the coordination, the articulation, and work on it as well, and also continuously think about the innovation, technological innovation, but also the devices that we're using every single day. This is how all the youth that right now is using all of these devices will become the natural actor of all of this digital data that we have. I would like to really go back to everything that has been said. I agree completely with everything that has been said, because the status quo today is not acceptable, just not acceptable. We have to integrate the digital, and this is the message that we are basically given to all the public actors. We have to continue daring, continue taking risks, and this is the only way for us to finally find the happy solutions and to succeed.
The thing that we all need to think about, regardless of whether you come from pharma or you're the state or the payer for healthcare, is that most of healthcare is not individual visits. It's not patients which will be treated with one visit and then off they go. Most is a care journey. And if you cannot utilize digital to that, we are stuck in a system where we are writing letters between different instances of care. You cannot measure what you do. It's very hard to reduce resources, and it's very hard to follow quality. So I think that starting to think about utilizing digital as a tool, not a means to an end, to accomplish this is what all of these sectors need to do.
On a atteint notre temps. Merci beaucoup, c'est un vaste sujet. Merci à vous.
Thank you very much. This is actually a very broad topic. Thank you so much to all of you.